It's time for the 3-question warm-up for renal 2. Let's get going. Which cytokines are produced by the Th1 cells? Well, Th1 cells produce IL-2 and interferon gamma, which leads to a stimulation of T cells and macrophages. Next question. Which penicillin drug would you use given each of the following infections? So first we have a UTI, and you might want to use something like amoxicillin because it has better gram-negative coverage. Neonatal infection, you're probably going to use ampicillin, usually combined with gentamicin. Syphilis, you're going to use good old-fashioned penicillin G. For Pseudomonas, you're probably going to use something like ticarcillin, carbenicillin, or piperacillin. And then next question here, what are the different classes of antiarrhythmics? Well, the mnemonic we use here is no bad boy keeps clean. So remember, for class 1, that's going to be the sodium channel blockers. Class 2 are the beta blockers. Class 3 are the potassium channel blockers. And then class 4 are the calcium channel blockers. All right, that's it for the warm-up. Let's get to that lecture now.
In this video and the next one, we're going to be talking about renal function. Now, in this video, we're going to talk about glomerular filtration and glomerular dynamics and renal plasma flow and so on. And then in the next video, we'll look at each individual segment of the nephron and discuss how the nephron turns that glomerular filtrate into urine. So let's start with the different ways we categorize the amount of water in our bodies. This isn't terribly complex, but you just kind of have to memorize these percentages. About 60% of your total body weight is water, and 1/3 of that is going to be extracellular fluid. So the majority of it, 2/3, is intracellular fluid. And of that extracellular fluid, 75% is interstitial fluid, and then 25% is actually circulating in the vessels as plasma volume. That's pretty much it. Another way to approach the same thing is the 60-40-20 rule, which is for total body water, intracellular fluid, and extracellular fluid. Because if 60% of your body weight is water, and 2/3 of that is intracellular, 2/3 of 60% is 40%. So 40% of your body weight is intracellular fluid. And then 20% of your body weight is extracellular fluid. That's all saying the same thing in different ways. Now, what does all that have to do with glomerular physiology? Well, the kidneys are responsible for filtering the blood through the glomerular filtration barrier. But only a small fraction of your total body water is actually found in the plasma. So you need to be really efficient at filtering and cleaning out the plasma that does circulate to the kidney. And when you think about it, not all of the blood that goes to the kidney actually goes to the glomerulus to be filtered. A large portion of it does, but some of that blood goes to provide oxygen and nutrients to the tubules. And then the tubules are capable of secreting certain substances into the filtrate. So renal blood flow is going to go to one of two places, either the glomerulus or the renal tubules. Now let's talk about why that's significant. First of all, we need to think about renal clearance, which is how much plasma volume that the kidney can clear per unit of time. So clearance is volume per unit of time, milliliters per minute, or liters per hour, or gallons per fortnight, or whatever. Volume per unit time. And to calculate clearance, you use the equation UV over P. Now this cartoon may help you remember that expression. UV, like UV rays in sunlight, over, well, P. UV over P. U is the urine concentration of a particular substance, V is the urine flow rate, and then P is the plasma concentration. So UV over P is the urine concentration times the flow rate divided by the plasma concentration. In the first part of that equation, urine concentration times the flow rate, or UV, that's also referred to as the excretion rate. How much of a substance is being excreted from the body per unit time? 100 milligrams per minute, for instance. Pay attention to the units. Milligrams per minute. Amount per unit time. Then if UV is the excretion rate, and you divide that by the plasma concentration, that's clearance. Milligrams per minute divided by milligrams per milliliter gives these units of milliliters per minute, which again is volume per unit time. So if you had a substance that would be filtered by the glomerulus, but then none of it was reabsorbed by the renal tubules, and none of it was secreted by the tubules into the filtrate, that means that the clearance of that substance would be exactly equal to the glomerular filtration rate. That's the rate at which the plasma filtered through the glomeruli. Well, as luck would have it, there's a polysaccharide called inulin that has these exact properties. It's freely filtered by the glomeruli, and it's not absorbed by the renal tubules, nor is it secreted by the renal tubules. So if you infused a little IV inulin, and then you measured the urine concentration of inulin, and the urine flow rate, and the plasma concentration of inulin, you could calculate the clearance of inulin, which is UV over P. And since you know that inulin is neither secreted nor reabsorbed by the tubules, you know that the clearance of inulin is entirely dependent on the filtration of inulin at the glomerulus. So the clearance of inulin equals the GFR. Now, what happens when the clearance of a substance is less than the GFR? Well, that means that that substance is going to the glomerulus and it's getting filtered, but then some of it is going to be reabsorbed by the tubules. So it's being taken out of the filtrate and put back into circulation rather than going on through the nephron and into the urine. Now, what if the clearance of a substance is greater than the GFR? Well, that means that the substance is going to the glomerulus, it's getting filtered, but then some of the substance in the blood that goes to the tubules is also being secreted by the tubules into the filtrate. So when the clearance is greater than the GFR, that means you have net tubular secretion of the substance. So even if some of the substance makes it through the glomerulus without being filtered, it still has a chance to get into the urine because the tubules can take that substance out of their own blood supply and then secrete it into the filtrate. So again, that means that clearance will be greater than GFR. So GFR is similar to clearance. It uses the same units, volume per unit time. And then just for reference, a normal GFR is around 90 to 135 milliliters per minute. I usually just remember 100. Then when we estimate GFR, if the patient's estimated GFR is, say, 50 milliliters per minute, then I know that the patient's GFR is about 50% of normal and that the kidneys are shutting down. But how do we estimate GFR clinically? It's not really very practical to give some IV inulin and measure plasma levels and urine flow rates. That's pretty involved. That's where creatinine comes in. Creatinine is found in the plasma naturally. It's a byproduct of breaking down creatine in the muscles. So creatinine functions very much like inulin in that it's freely filtered, it's not reabsorbed by the tubules, and only a tiny, tiny amount is secreted by the tubules. So instead of going to all the trouble of measuring the clearance of inulin, we can calculate the creatinine clearance, and that's going to be a pretty good estimate of GFR. Now, you don't need to know how to calculate a creatinine clearance for step 1, but that's how we use the creatinine clearance clinically to estimate GFR. Next, let's talk about renal plasma flow. So not all the blood going to the kidneys is going to the glomerulus. The renal plasma flow takes into consideration both the blood going to the glomeruli and the blood going to the tubules. And just like inulin is ideally suited for measuring GFR because it's not secreted, it's not reabsorbed, we use a substance called para-aminohippuric acid, or PAH, to estimate renal plasma flow because PAH is both filtered by the glomerulus and actively secreted in the proximal tubule. So all the PAH that makes it to the kidney is going to end up in the urine and be excreted. So the renal plasma flow rate is the clearance of PAH, or the U of PAH times V, divided by the P of PAH. Now let's talk about filtration. Like I said, not everything that goes to the kidneys is filtered by the glomerulus. The filtration fraction is the portion of blood going to the kidney that's filtered through the glomerulus. So the equation for filtration fraction is GFR divided by the renal plasma flow rate. That's another equation you need to know. GFR over renal plasma flow. And again, clearance of creatinine divided by the clearance of PAH would be a good estimation of filtration fraction. And normally it's about 20%. About 20% of the plasma that's delivered to the kidneys gets filtered by the glomerulus. So, in terms of hemodynamics, what determines the GFR and the renal plasma flow, and therefore what determines the filtration fraction? Well, think about the afferent arteriole. We've mentioned before that prostaglandins are vasodilators. So prostaglandins will dilate the afferent arteriole. So if you give NSAIDs and you inhibit the production of prostaglandins, that's going to constrict the afferent arteriole. And obviously, as you do that, you can have less renal blood flow and less GFR. And because both of those factors are decreasing, there's no net change in the filtration fraction. Your filtration fraction will still be about 20%, even though both your renal blood flow and GFR have decreased. Then on the other side of the glomerulus, in the efferent arteriole, the potent vasoconstrictor angiotensin II preferentially constricts the efferent arteriole. So constriction of the efferent arteriole is going to cause a back pressure into the glomerulus. You have some congestion of the blood in the glomerulus. And as a result, the overall renal blood flow decreases, but relatively more plasma is going to be filtered, so the GFR increases somewhat. If the afferent stays open but the efferent clamps down, the plasma coming into the glomerulus is looking for a way out, so more of it's going to ooze through that glomerular filtration barrier. So GFR goes up and filtration fraction goes up. Now ACE inhibitors do the exact opposite since they decrease the amount of angiotensin II. So ACE inhibitors will relatively dilate the efferent arteriole, so filtration fraction decreases. Let's look at this on number 4 in your study guide. Number 4 says, how will the following changes affect renal blood flow, GFR, and filtration fraction? So take a moment or two and try to reason through all these, and then we'll go through them together. The first one says constriction of the afferent arteriole. So the GFR would decrease, renal blood flow would decrease, and the filtration fraction would have no change. We talked about that. Next one is constriction of the efferent arteriole. Again, this is what angiotensin II does. So GFR would increase, renal blood flow would decrease, and filtration fraction would increase. Dilation of the afferent arteriole is going to cause an increase in GFR, increased renal blood flow, and no change in filtration fraction. Dilation of the efferent arteriole will decrease GFR, increase renal blood flow, and decrease filtration fraction. Increase in serum protein. Now, what's going on here? Well, with higher protein content of your blood, that osmotic load of the protein is going to keep blood in the vessels, so less blood is going to escape. And so an increase in serum protein will decrease GFR for that reason, but it's not going to do anything to the renal blood flow. So the net result here would be to decrease the filtration fraction. What about a ureter stone obstruction? If you obstruct a ureter, then urine's going to back up into the kidneys and back up into the renal tubules, and you're going to get a lot of back pressure all the way up into the glomerulus. And if you can imagine a high hydrostatic pressure inside Bowman's capsule, that's going to favor blood staying in the capillaries rather than being filtered, so the GFR will go down. The renal blood flow won't change, so as a result, the filtration fraction is decreased. ACE inhibitors are going to inhibit the constriction of the efferent arteriole. And so by inhibiting the constriction of the efferent arteriole, your renal blood flow will go up. But as a consequence of this, your glomerular filtration rate is going to go down. And so although you're improving renal blood flow, you're actually decreasing the filtration fraction with ACE inhibitors. And this is why when we start a patient on an ACE inhibitor, their serum creatinine goes up just a little bit because the GFR is slightly worse. So it's healthy for the kidney to have more blood, but it's not necessarily healthier for the body as a whole because the kidneys aren't filtering the blood as well as they used to be. And then NSAIDs are going to constrict the afferent arteriole, and that's going to decrease renal blood flow, decrease GFR, and it'll have no change on the filtration fraction. All right, we're almost finished. Just a few more equations to be aware of. If you're looking for the filtered load of a substance, it's the GFR times the plasma concentration of that substance. We talked earlier about the excretion rate. It's the top of the clearance equation. It's U times V, urine concentration of that substance times the urine flow rate. And so what's reabsorbed is everything that's filtered minus everything that's excreted, because the only thing you'd have left would be the things that would be reabsorbed. And then secretion is everything that's excreted minus everything that's filtered. Then what about the clearance of things that your body doesn't want to excrete, that it would prefer to hold on to, like glucose or amino acids? Well, both glucose and amino acids are freely filtered, so in order to hold on to them, they have to be reabsorbed by the renal tubules. As long as the plasma glucose stays in the normal range, your kidneys are perfectly capable of reabsorbing all of that filtered glucose. There's a sodium-glucose cotransporter in the proximal convoluted tubules that takes care of this. So the proximal tubules are the workhorses of the nephron. They reabsorb most everything. But if the plasma glucose gets above about 160, you start to exceed your body's capacity to reabsorb glucose, and you start to lose some glucose into the urine. And then at a plasma glucose of 350, those transporters are fully saturated, so you're going to be spilling out a lot more glucose in your urine as you approach that serum level of 350. Then in terms of amino acid clearance, there are sodium-dependent transporters for amino acids in the proximal tubule as well. There are 3 distinct carrier systems for positive, negative, and neutral amino acids. And one of the problems you can see is something called Hartnup disease, which is due to a deficiency of the transporter for neutral amino acids, particularly tryptophan. So if you don't have tryptophan, you can't make niacin. If you don't have enough niacin, then you're going to have the 3 Ds of pellagra: dermatitis, diarrhea, dementia, and then possibly the 4th D, which is death. All right, that's it for the glomerulus. In the next video, we're going to move out of the glomerulus and start looking at the different segments of the nephron in detail, starting with our workhorse, the proximal tubule. But first, let's go ahead and work through the end-of-session quiz and go over those answers. First question. A 40-year-old patient of yours weighs 100 kilograms. What's her estimated plasma volume? Remember that the extracellular fluid is about 20% of the patient's weight. So the extracellular fluid here is 20 liters, but of that 20 liters, only 25% is plasma. So here the plasma volume is 5 liters. Next, what effect will a renal stone that obstructs the ureter have on GFR and filtration fraction? So it's going to decrease the GFR and decrease the filtration fraction. Next, what's the maximal serum glucose concentration at which glucose can still be absorbed in the tubules? Remember we said you're going to start to spill glucose at around 160 or so, but you're going to reach saturation of that mechanism at 350 milligrams per deciliter. Next, what vitamin deficiency results from Hartnup disease? Remember, Hartnup disease is a deficiency of tryptophan, which leads to niacin deficiency. And don't forget that niacin is also called vitamin B3, and also deficiency of niacin is called pellagra. Next, what substance can be used to estimate GFR? Creatinine and also inulin. But creatinine is the one we use most often clinically. And then what about renal plasma flow? You can use PAH, para-aminohippuric acid. Next, what's the equation for the renal clearance of any substance? It's UV over P. Urine concentration of the substance times V, or the urine flow rate, divided by the plasma concentration of that substance. All right, that's it for renal 2. I'll see you next time.